like to invite Dr. Gavin Tan. We're going to shift gears from macular hold and listen from Dr. Tan on tips and tricks in pediatric retinal surgery.
Okay, good evening, everybody. Thanks to the organizers for inviting me to give this presentation. These are my financial disclosures. So I think before we think about pediatric retinal surgery, we need to be very clear about the indications, and they can range from tractional retinal detachments. Oops, there are no slides. Hi, slide, yes. So they can range from tractional retinal detachments, which is often a result of vascular diseases like ROP, FEVR, incontinentia pigmentae, etc. It could be the result of inflammatory or trauma. It could be purely rhegmatogenous. And you need to be clear what your aim, your indication is. And it's also very important, as an important trick is to really counsel the patients adequately. If not, difficult, unrealistic expectations is a big problem after surgery. I think it's always very important to remember scar buckle is a critical tool in these kids and pediatric patients because you often cannot remove all the posterior hyaloid. And if you can do it primarily as a scar buckle, then you avoid removing the vitreous. If you do have to do a vitrectomy, think about the positioning of the sclerostomies. The eye is smaller, especially in infants, and there you will end up with a transpars plicata sclerostomy rather than a transpars plana. And there has been research that showed with various kinds of congenital abnormalities, there are differences in where the pars plana will be, and the site for the sclerostomy will need to be modified. In my small children, I always like to try and indent on table so you can identify when you have a view where the best position of a sclerostomy will be. The length of the eye also makes a difference. You may want to do an ultrasound beforehand in an EUA to measure that. And the consideration always is, where possible, do a lens sparing. But when you have to access very anterior pathology, then you may need to do a lensectomy. Translimbal, when you're committed to doing a lensectomy in the babies, can be a useful technique. And again, remember the pediatric hyaloid is extremely adherent. Do what you can just to relieve the traction because you really want to avoid a break. You may need to use tamponade if there are breaks, and there are various options available. And you want to make sure you remember what the original pathology was, because often there is ischemic retina. If you don't address the ischemic retina, you've not solved the problem altogether. And my preference is almost always to suture the sclerostomies, no matter how small gauge I do, because I can't expect children to be reliable. So in particular for ROP, you really are trying to relieve these various areas of traction. And again, you're just trying to remove the areas of traction that's causing a detachment and not trying to remove the whole posterior hyaloid, which in infants it tends to be very adherent. You can get very successful outcomes of stage 4A and B, as has been shown in many studies, and usually a lens-sparing vitrectomy will do. This is an example. As you can see, I prefer not to go transconjunctival. I still prefer to open the conch because I'm going to suture anyway. Here, I'm trying to do lens sparing, so I'm about 1.5 millimeters behind the limbus here. You just want to ensure you're removing the areas of traction. I always like to stain, and don't be too aggressive with the vitreous removal. Just enough to relieve that traction on that ridge so that that ridge can then slowly resolve over time. And don't forget to do the adequate laser at the end of the case. For stage 5, it's a little bit more complicated because the outcomes tend to be very, very poor. So often you may only consider this in bilateral disease where there's no other option for any visual outcome for the kid if there's no surgery done. And the visual outcome tends to be form vision or very, very poor vision. Again, there is a new IC eye-crop categorization of stage 5, which can be useful to guide the anatomical outcomes of surgery. And this is an example of a case of stage 5 where, again, I'm going to sacrifice the lens. So I do it translimbal. You may start off with just filling the anterior chamber with, and the anterior part of the eye with viscoelastic to keep it stable while you create an opening in that hyaloid membrane and then slowly dissect the tissue away. You often will not end up with a flat retina at the end of the surgery. It does not matter. as long as you're quite confident you've relieved most of the traction, as you can see in this case. And again, relieve the traction, don't create a break. That's the principle. And here, slowly, fluid comes down. Endoscope is useful. I won't go into it too much because I think the next speaker is going to speak about it a little bit, but it can help you avoid a lensectomy in some of the more cases with complicated anterior pathology. For FEVR, again, you need to remember you're trying to relieve traction. Sometimes you can do it with a scleral buckle alone. Other times you need to do a vitrectomy. If the fibrovascular proliferation is very extensively attached to the lens, then you may need to sacrifice the lens in order to relieve the traction. And often, when in severe traction, combined vitrectomy with an encircling band can be useful. This is an example of a very advanced FEVR bilaterally at a young age. Here, the lens had to be sacrificed. And again, so a translimbal approach was taken, and again, the fibrovascular tissue was removed very, very carefully and gently, not to create a break. In this case, one eye did well, the other eye did not, in spite of repeat surgery for silicone oil in one of the eyes. Another case where it's tractional retinal detachment in a slightly older child, and in here there was a lot of temporal and peripheral traction. So we did do a combined scleral buckle with an encircling vitrectomy with an encircling band, and that helped relieve some of that peripheral traction. Again, staining is very, very critical to ensure you can remove the posterior hyaloid in these cases. And eventually we could flatten the retina and silicone oil was placed. I think there's some evidence that in progressing macular folds, early intervention can be useful. This case that was presented by Dr. Shinji's group, we had a similar case with progressing retinal traction in spite of laser that benefited from removal of the posterior hyaloid as well as the internal limiting membrane. And again, you just remove it to the ridge. You don't want to remove too much peripheral tissue that might result in an inadvertent break. And here, ILM was also removed. And the patient did well without progression of the fold, and maybe some unfolding of the fold subsequent to that. The last area that you may commonly encounter in kids is persistent fetal vasculature. And this is an example where, again, if it affects the visual axis, you need to go through that whole discussion with the parents. And if it is an older child, then you may decide to do an intraocular lens at the same time. But in older children, you must also remember, because of dense amblyopia, the visual prognosis can be quite guarded. Here, some of these retinal folds can mimic PFV, and you really don't want to end up cutting a retinal fold, so you need to distinguish what the tissue is. If you're unsure, do a very good examination under anesthesia first. Here, I'm really just diatomizing to prevent bleeding and then transecting the stalk, the vascular stalk, and this patient eventually, because of that central posterior capsular opacity, did have an intraocular lens placed, and actually did surprisingly better than we expected with 20/94 vision 2 years later with patching. So again, post-operative operative considerations are important. Amblyopia management, refractive correction, and patching is extremely important if you want a good outcome in these children. So in conclusion, surgical techniques are very different from adults. You really need to position the sclerostomies properly and then check on table. Don't forget the scleral buckle. We're not vitrectomy-only surgeons. And like many things in life, less is more. And early intervention is really important to determine the outcome, where you can try to avoid amblyopia with good post-operative refractive management and patching. Thank you very much. And of course, we would like to see you in Philippines at the end of the year and Singapore next year for various meetings. Thank you.
Thank you so much, Dr. Tan.